Hello, my name is Brian Buckman. I'm the Unit Director for Family Practice here at Huntsville Hospital. I am also an MSN student with the University of North Alabama. This semester I'm taking the course Statistical Concepts for Nurses. We have a project where we have to review 2 articles of a peer-reviewed journals that have to do with our clinical practice. I have chosen 2 articles that deal with central line associated bloodstream infections. The name of the 2 articles that I'll be reviewing are Sustaining Reductions in Catheter-Related Bloodstream Infections in Michigan Intensive Care Units, and the second is a survey of preventive measures used and their impact on central line associated bloodstream infections in intensive care units. The first article that I'm going to review was an observation study done in 2010 by Pronovost and several of his colleagues. It was a large observation study that was done over time, anywhere from 18 to actually the longest time was 36 months. So this is one of the robust studies that a lot of people go to when they look at how can we reduce CLABSI rates in our hospital setting. Before I go to the problem statement, let me give a little background information. CLABSIs cause considerable morbidity, mortality, and healthcare cost. An estimated 82,000 CLABSIs and up to 28,000 deaths occur in the ICUs annually, and infection rates cost about $45,000 each time they have a CLABSI. The information is good background that leads to the following problem statement. Achieving sustainability has been a major challenge for the quality improvement field. A conceptual model these researchers used was one that would allow them to translate evidence-based practice interventions into their practice and to promote a culture of safety. This model had the following concepts: focused on processes and systems instead of just the patient care at the bedside, a multidisciplinary collaborative approach that involved physicians, nurses, pharmacists, a multi-dynamic team. It also encouraged local and system adaptation of best practice interventions, and the concepts were embedded in a process to roll out the implementation with the following stages: engagement, and that was getting all the stakeholders involved up front, educating everyone on the best practices and the monitoring systems they would have in place, execution and how they would execute it and when, and of course the evaluation processes and the data collection. In this project, the goal was to evaluate the extent to which ICUs participating in the initial Keystone ICU project sustained reduction in rates of CLABSIs. From this objective, the following research question can be developed. The article didn't refer to a specific research question, but one could be obtained after reviewing the article. So it's the question: will ICUs participating in the Keystone ICU CLABSI project using a multifaceted quality improvement intervention and conceptual model have sustained CLABSI reduction rates 18 to 36 months compared to their initial baseline rates? So from this question, we can develop the following hypothesis. We hypothesized that the bloodstream infection rate would remain low during the sustainability period relative to the original baseline for each ICU. The independent variables for this study are the reduction in quality improvement interventions, those best practice measures they put in place, and also that conceptual model that they put in place. The dependent variable is the CLABSI incident rate for each ICU. The research design for this study was a prospective cohort study that used that collaborative model that I've already referred to. It was a clinical trial over time to see if their CLABSI reduction rates were sustained after implementing the reduction interventions and this conceptual model. The population was 90 Michigan ICUs, representing 67 hospitals, and they followed them over an 18-month period, and some of them even a further period of time, up to 36 months, to show whether the CLABSI reduction rates were sustained. So during this study, each ICU developed a multidisciplinary team to help with the development and the implementation and rollout of the best practice interventions. This multidisciplinary team worked with the infection control departments at each hospital to collect this data. The data collection methods most hospitals already have in place, because this collecting CLABSI incident rates based on 1,000 central line days is something that every hospital already has to collect and turn into the federal government or to CMS. So the infection control departments already work with usually each department of the hospital to collect this information. So that process was already in place. So these units and the infection control departments did collect this data and send it to the Keystone Center for Patient Safety and Quality, who gave consistent feedback to the key stakeholders and to each ICU and the infection control departments. The 90 ICUs reported over 1,500 ICU months of data and over 300 catheter days in this data collection. The CLABSI rates were analyzed as medians and interquartile ranges and as means and standard deviations. In conclusion, for this large study, the findings were that the study revealed a reduction in CLABSI rates during the initial evaluation period and for the 18-month sustainability period, with a greater than 60% chance of reduction in CLABSIs from the baseline sustained at the end of 36 months. The strengths for this study is that it was one of the relative few robust designed and evaluated large-scale quality improvement projects that have shown substantial improvements. Even fewer projects have evaluated the sustainability of such results. And that's the reason this study was such a good study, is because it did it over time and showed that it was sustained reduction in CLABSI rates. So the study used a multifaceted quality improvement and a conceptual model, and another strength was that the ICUs were given constant feedback on their results. Limitations for this study is that there was not enough funds to do a thorough investigation to determine all the factors or variables that led to the sustained reduction in CLABSI rates. And there wasn't a way to determine if incentive reimbursement for performance, such as the reduction in CLABSI rates by payers like CMS or third-party payers, had an impact on the results. Another limitation was that new advances in products and techniques on CLABSI rates were not evaluated, such as the antibiotic injected central lines or new caps that are coming out that should help with reduction in infections. So, on to the next article for review. The second research article being discussed involves a surveillance program on CLABSI interventions in Quebec ICUs. Gonzalez and his colleagues did a study, and it involved many ICUs in Quebec, but they wanted to focus on, or the primary focus was compliance with the monitoring process, because they felt that when we have compliance with the monitoring process, sustainability tends to happen, or those for longer periods of time of reduced CLABSI rates. So, although the article didn't address a certain problem statement, one could be identified after reviewing the article. In the article it says, compliance monitoring of implemented measures to prevent CLABSIs is not yet widespread in Quebec ICUs. So they knew that it was a problem and needed to be addressed. So a conceptual model also was not specifically addressed, but they did refer to one interesting, the same one that was used in the previous article by Pronovost and his colleagues. This conceptual model focused on ways to take the best practice measures and implement them into a practice setting for success. It involved the same concepts, which are engagement, education, execution, and evaluation. So, the research question, again, in this article, could be determined from the goal that they mentioned in the article, or the aim, which said, we aim to determine what preventive measures have been implemented, if compliance to these measures were monitored, and its impact on CLABSI incident rates. So a question can be developed on this. The research question could be, if ICUs implemented best practice CLABSI preventive interventions and monitored compliance with these interventions, will they have reduced CLABSI rates over time? From here, the hypothesis could be, if ICUs are compliant with using best practice CLABSI preventive interventions and with measuring compliance with these interventions, their CLABSI rates should be lower than those ICUs that are not compliant. So, the variables used for this study, the independent variable, are the CLABSI quality improvement interventions and the compliance monitoring of these interventions. The dependent variable for this study is the CLABSI incident rate over time. Okay. The design was a 77-question cross-sectional survey based on recommendations from the CDC guidelines and the Safer Healthcare Now campaign from the Canadian Patient Safety Institute. This survey was an online survey that was sent to the infection control departments of each hospital. The population was 48 Quebec hospitals with ICUs, but they had to contain at least 10 beds. Each hospital had an infection control department that completed the survey, and only 42 of the 48 actually met the criteria because 6 of the hospitals didn't fill out all the recommended questions on the survey. The ICUs consisted of adult, pediatric, and neonatal populations. There were 2 data collection methods for this study. The first was an online survey. It was designed using the Fluid Survey software and was sent to the infection preventionists using an automated, personalized email invitation. The second collection method was one that is already in place that I mentioned earlier that all hospitals have because they have to collect their CLABSI incident rates per 1,000 central line days. For data analysis, descriptive statistics were used. The variables analyzed were limited to hand hygiene, the use of caps, masks, sterile gowns, sterile gloves, full body drapes, daily review of the central venous catheter or CVC, and regular evaluation of the CVC insertion site. Poison regression was used to estimate the change in infection rates per 1,000 CVC days from baseline to 2012 and 2013 post-survey. Since this was a large study as well, what they found is that it allowed the researchers to better understand preventive measures in Quebec ICUs and if those measures worked. It also looked at or showed them the implementation of compliance monitoring and if both were effective in reducing CLABSI rates over time. So the study did show or reveal that the ICUs with compliance monitoring processes in place did have a greater CLABSI reduction rates than those that did not have monitor compliance. Strengths of this study had a large population, it had a large amount of data for analysis, it used process improvement and conceptual models, it had an ease of an online survey, and the ICUs in the study were all in a pre-existing project done with the same group for this study. Limitations. Again, as I mentioned earlier, 6 of the 48 ICUs participating couldn't be used because they didn't report all their required data on the survey. The study method wasn't designed to assess for causality between CLABSI rates and compliance monitoring. And the survey was done after the implementation of intervention phase, so it was unclear if the compliance monitoring was initiated with implementation or was done at a later time. So, as professionals, what can we gain from these studies? The same thing that I was looking for. What interventions do we need to put in place to have sustained reduction in CLABSI rates over time? I think because at our hospital and at my unit, we have reduced rates when we focus on it, but if we start focusing on something else or take our eyes off on it, then those CLABSI rates may go back up. So what can we do for sustainability of reducing CLABSI rates? Number 1, multifaceted process improvement and conceptual models can aid in the success of long-term reduction in CLABSI rates. Using proven approaches such as engagement, education, execution, and evaluation can also aid in reduction of CLABSI rates. And probably the number 1 thing that I realized during this study that I'll probably start implementing in our units and recommend to our hospitals, since I chaired the task force for CLABSI reduction in our hospital, is compliance and monitoring implemented interventions is also key to sustaining reduction in CLABSI rates. We've got to have these processes in place, especially a monitoring system, to make sure that we continue with these best practice measures in our hospital. Thank you for watching this presentation, and the following are the references that I used for this presentation. Thank you.